and management of hemoglobinopathies, which is indeed a huge topic, and we've lost some time already. So I will be very brief, but I will, this is a very relaxed format. It is an informal format. So I think we can afford some time to invest to what my mind is one of the most important topics in hematology, not just because of the scale of this problem, but because every general pediatrician has to sort of deal with this. It's not a specialized hematologist subject, whether you like it or not, whether you enjoy it or not. I think each of us is involved in early recognition, in diagnosis, and very frequently have to be involved, at least on a shared care basis, in the ongoing management. Sir, are we able to get our slides now?
When the slides are on the screen.
So if you can put it in the share screening mode. So the next slide just shows where we are in terms of the global burden of hemoglobinopathies. So if you look at the colors on the globe, you can see that moving from blue to deep red, you see extreme, changes in the prevalence of hemoglobinopathies. And as you can identify our own country, it varies from not so red to very red. So we are only behind Africa in terms of our burden of hemoglobinopathies. Next slide.
Detailed slide change.
So it is the commonest genetic disorder. And if we include all the hemoglobinopathies, not just the serious hemoglobinopathies, we have the highest burden. Just for thalassemia itself, that includes homozygous thalassemia, our expected annual burden is over 12,000. And for sickle cell disease with various severity, our burden is over 40,000. So every year, 50,000 new children with hemoglobinopathies are added to our existing pool. This provides, this poses unique challenges in how to manage every child universally, adequately, especially when 2/3 of our population is in the rural setting, and many patients with sickle cell disease actually belong to the most underserved communities in our countries. No, there is no dispute whatsoever that prevention is the way forward, but with 25 million births every year, and with so many of them at risk of having a child with hemoglobinopathy, this is a humongous task, but something that policymakers, advocacy groups, and the medical community are trying to tackle. Next slide. So my presentation today will focus on the clinical recognition and symptomatology, the basic lab work, and this is not very difficult and fortunately is now widely available, principles of management of these conditions, and I will touch upon a little bit about recent advances, because in the last decade, finally hemoglobinopathy has had its due in terms of research and development, with many new molecules and progress made in this field. And I think it's only just that all of you know little bit about this. Next slide. So we all know that hemoglobinopathies are heritable disorders of abnormal structure of the hemoglobin. They can either be quantitative defects, which is thalassemias, or they can be qualitative disorders or Cobain gene, which includes the whole group of sickle cell disorders. Could I have the next slide? So in terms of, optimal management, it is vital that we recognize these conditions early, and not all of them have the florid clinical presentation of a thalassemia major. Sometimes it may be subtle, and there is a whole spectrum of clinical features. The basic lab work is really very simple. It involves the RBC just looking carefully at the complete hemogram that almost every child with anemia or any other symptom will get done. We have some screening tests which are meant for community screening and assessment of prevalence. And finally, we have tests for definitive diagnosis, which is HPLC, widely available, not expensive at all now. And for confirmation in challenging cases, we have mutational studies. Next slide. So ethnicity, when we look at a child who has some, anemia, and we think there may be hemoglobinopathy, just history is so important, where they belong from. It's not entirely, completely accurate now with so much migration and intercultural marriages, but still ethnicity matters. Beta thalassemia is prevalent across the country, but has a higher frequency in certain communities, the Sindhis, Punjabis, Gujaratis, the Mahars, Lohanas, and Gaurs. HB sickle is widely prevalent in tribal population of southern, central, and western states, reaching as high as 48% in certain communities. HBE, as the name suggests, is mostly in the northeast and has a carrier frequency of up to 50%. We were supposed to share some resources, but I thought it is really not probably possible for you to go through these resources. So anytime when you are preparing for your exams, or when you are just want to know more about hemoglobinopathies, these are the 4 resources that I would suggest. The TIFF guidelines on transfusion dependent and non-transfusion thalassemias, the ASH guidelines for sick, which is American Society of Hematology guidelines for sickle cell disease, and finally the National Health Mission guidelines for prevention and management of hemoglobinopathies. So if you just have these 4 resources, I think that's all any of us needs to know about what is the optimal management of these conditions. Next slide, please. So we come to thalassemias. Can we move on to the next slide? And it is a huge spectrum. We have the beta thalassemias, where we have the thalassemia carrier state, the intermedias, the major, and again a whole group of mixed hemoglobinopathy, where beta thalassemia is co-inherited with another hemoglobinopathies. We have alpha thalassemias, of which really the HBH disease is the most important. Next slide. So we all know thalassemias are autosomal recessive disorders, and I really need to do not labor on this point. Can we move to the next slide? And beta thalassemia essentially is where there is a mutation on one of the 2 beta globin chains. A carrier has one of these mutations, and again the partner has another mutation, which may be identical or different. There are over 300 mutations in India that cause beta thalassemia, but really about 6 of them are responsible for 90 to 95% of the beta thalassemia that we see in our country. Next slide. The clinical features that we see in thalassemia are essentially: 1, due to hemolysis, due to excess of alpha chains, which leads to extravascular hemolysis, reduced red cell lifespan. This in turn results to ineffective erythropoiesis, which is responsible for the facial changes, the hepatosplenomegaly, and sometimes masses of extramedullary hematopoiesis that can cause the cord compression even. Iron overload is an inevitable consequence. So if we boil down to the symptomatology and the complications seen with thalassemia, it really boils down to these 3 factors. Next slide. And as you can see, essentially this cartoon or diagram shows that how every part of the organ may be affected, which is even further exemplified by the next slide, which shows that from the head to toe, every single organ can be involved with thalassemia. Can we move on to the next slide? Can be involved with either because of the consequences of suboptimal management, or indirectly due to iron overload leading to endocrinopathy, cardiac dysfunction, liver dysfunction, infertility. So really suboptimal management would mean that no single organ is spared from the consequences of the thalassemic disorder. Next slide. So let's start with minor, which is something so prevalent in our country. So and on average 3 to 4% of us, and many of us, so we are 230 participants on this platform, many of us will actually may be a thalassemia carrier are completely unknown to us. In some population, this can cross up 15%. Most carriers are asymptomatic. They may or may not have mild anemia, but can have normal hemoglobin. And for our country, it is very vital to differentiate these from the from iron, widely prevalent iron deficiency, and this can easily be done just based on very simple tests available on the complete hemogram. But we need to be aware that both may coexist in a given child, and there is no harm whatsoever in giving iron supplement to a child with thalassemia minor who you think may also have iron deficiency. Please go ahead with the next slide. Thalassemia major or homozygous beta thalassemia, what we used to call, but now we refer to this as transfusion dependent thalassemia, becomes symptomatic very early in the first few months of life, as early as 3 to 4 months, with pallor, lethargy, poor feeding, hepatosplenomegaly. They may begin to have hemolytic facies. They often may present for the first time with a fever, febrile illness, because they get recurrent infection. And if they are not, transfusion is not initiated promptly, they will end up with growth failure very early in life. Next slide. What is challenging is to diagnose and label the non-transfusion dependent thalassemia, who by definition do not require transfusion in the first 2 years of life to maintain adequate growth. They can present really at any age, maybe at 3 years, maybe at 8 to 10 years, with pallor, growth failure, abdominal distension due to the hepatosplenomegaly, and facial dysmorphism. They may require intermittent or regular transfusion subsequently based on a number of factors, and I'll come to that in a minute. And the important thing is, for these patients, we have to individualize the management for every individual patient. Next slide. So there is a huge spectrum of the non-transfusion dependent thalassemics who may rarely require a transfusion and do really quite well with minimal management. Most of them will be on hydroxyurea. And this spectrum goes all the way to patients in whom we may opt to start regular transfusions very early in life. And I will just come in a minute to why this heterogeneity within thalassemias, that with the identical gene, you may have a completely different clinical behavior. Next slide. So the diagnostic workup really in all of medicine, full medical and clinical history and family history for hemoglobinopathies, it what will suggest you a diagnosis in the vast majority. The automated Bulset counter combined with a good peripheral smear examination can virtually give you a presumptive diagnosis in most. So basic hematological workup, and in thalassemia minors, of course, if there is there is coexisting iron deficiency, or you may need, then you may need to do other studies. Finally, HPLC, which is widely available, gives us as to what variant of hemoglobin we are dealing with in our country. And there are many, many variants, over 300, some many of them which are not clinically significant. And if we need confirmation or if we need prognostication, we can have molecular confirmation, and I'll share something about that in a minute. Next slide. So as you can see, the peripheral smear of thalassemia major is described as a messy or a dirty slide, so that nothing seems to be okay. There are target cells, there are teardrop cells, there are microcytosis and isocytosis, almost all these things. On the bottom, where it is which is labeled as C, is the Heinz body, is the preparation for inclusion bodies that we see in alpha thalassemia. Alpha thalassemias are notoriously difficult to diagnose without molecular workup. And on the B, I'm just showing you a slide, as it may still be sometimes shown to you, that is a F cell staining, where when we didn't have HPLC so widely available, you could just stain a peripheral smear and see how many cells have very high content of fetal hemoglobin. On the right, you see the HPLC graphs, which is what gives us the diagnosis. We now use high pressure liquid chromatography, and really essentially it is that a small sample of blood is moved through a silica gel column at high pressure, and a buffer is added. And different types of hemoglobin elute at different times, which we refer to as elution or retention times. And in a longitudinal, that is why it is displayed in a longitudinal manner. And depending on where the most of the hemoglobin is, the analyzer quantifies this. And as you can see in the first graph on the top in the HPLC, there's a very high peak of at the fetal hemoglobin elution point. So which means that we are probably dealing with a homozygous beta thalassemia. The middle graph shows that there are two peaks, one for fetal hemoglobin and one for E, because it elutes much later. So that is a patient with E beta thalassemia. The final graph on the bottom shows a very early spike of HbH. So this is a patient of alpha thalassemia, but because this spike comes so early, it is mostly missed in most analyzers, and that's why you have to be very careful in analyzing a patient with HbH, because as you can see, it's really, you may completely miss it. Next slide. So these are some other graphs that show the one on the left shows again two big peaks. One is for sickle window and one is HBD. So this is HBS D thalassemia. On our right, we have another patient who has a high peak for HBS and a high peak for HBF. So this is S beta, or beta sickle thal. Next slide. So I'm just showing you these graphs because they are frequently shown to you in your exams or OSCEs. And again, you just have to see where the peaks are. Most of the information is given on those charts, and you just have to see it with little patience, you will be. But some of them can be very difficult and require a trained lab hematologist. As you can see, HBE and HBD Iran, they elute almost at the same time, but it is slightly different. So to interpret something like this, it has to be some degree of training and experience is required. Next slide. So this is an example of a mutational analysis. So we almost always do it now because it helps us in the prenatal diagnosis. If a patient comes to you heavily, is already transfused, there is really no way to get an accurate HPLC result from that patient for many, many weeks, and the patient will need transfusion again prior to that. We could do family studies, which is indirect evidence, but this kind of mutational analysis is confirmatory, can be used for antenatal diagnosis in future, and it can also give us some additional information. For example, this patient has co-inheritance of alpha thalassemia trait, which can predict that the clinical severity may be slightly milder. Next slide. So I just want to mention the screening test. So we have the Nestroff set test. Do read up about it, because though we don't use it, since HPLCs has become so widely available, there are other techniques like capillary electrophoresis which can be carried into the community. But it still gets asked in the exam, and it is still a very cheap test which has a sensitivity and specificity of between 80 to 90%. So you should know about this. It is based on the principle of decreased osmotic fragility of thalassemia carriers, and that's why when you mix it with saline, there is less hemolysis, and this is what it is. I think it's best if you read up a little bit about it. And for sickle, we have a similar screening test, which is the sickling test. Next slide. So why the heterogeneity in thalassemia? First of all, the mutation itself may matter. Over 300 mutation globally, more than 30 in India, but 6 of them are responsible for more than 90 to 95% cases. So these are the primary genetic modifiers, but in addition, we have the secondary genetic modifier. For example, the co-inheritance of alpha thalassemia trait, which reduces the severity, the co-inheritance of hereditary persistence of fetal hemoglobin. And then we have tertiary genetic modifiers, which may just reduce the impact of the primary gene defect in a given patient. Next slide. So in addition to the homozygous beta thalassemia, we have all these combination with, co-inheritance of other conditions which may impact on the clinical behavior of thalassemia. And again, that's why you have to interpret this with a given patient in their clinical details based on their HPLC as to what are management and how, what is the likely clinical course going to be for that given patient. Next slide. So I'll just briefly talk about alpha thalassemia. So we can have from 1, 2, 3 or 4 gene defects. The 1 and 2 gene defects are really clinically insignificant. The 4 gene defect or the hydrops fetalis is fatal in it, in utero. So it is really when we are confused, maybe in a patient with moderate anemia or sometimes even mild anemia, is when you have 3 gene deletions, which is the HBH disease. And again, this may be difficult to pick up on a HPLC unless there is a very experienced hematologist, but can be confirmed on the mutational analysis. But a good screening test is the HBH slide preparation that I showed you with the basophilic staining, and that is easily widely available and very cheap to do. So it can be used as a good screening test. Next slide. So this is just again a similar preparation, and again just highlighting that this peak elutes very, very early. Next slide. Could we move to the next slide? So in terms of management of thalassemic disorders, many of these are similar to the management of sickle, for example, transfusions in certain patients. So I will cover most of that here. So we have our conventional treatment, or the standard of care continues to be optimal transfusion and chelation. We have some drug modalities, or we use the scientific basis of fetal hemoglobin induction, and I'll come to that in a minute. The curative treatment, which is widely available in many countries, is BMT. I can say prevalent, available, but it is not accessible to many because of a number of reasons. And finally, we have gene therapy. We have all of us been hearing about it for the last 3 decades or so, but it has finally come to a point where it is moved from the lab to clinical practice, and at least in Germany, it is now available as a therapeutic modality, and many other clinical trials are ongoing. Next slide. So in terms of optimal transfusion, when do we start? When we see a child 4 months, hemoglobin is low, we do, should we initiate transfusion, or could it be an intermediate and may not need a transfusion for some time, for few years? So the current guideline is to begin regular transfusion if we have hemoglobin of less than 7 on 2 occasions, 2 weeks apart, because one, if you see one reading, there may be an acute infection that has suddenly dropped the hemoglobin, but once the infection is treated, it picks up, and that's why it's a major lifetime commitment to start somebody on a regular transfusion program. So we need to, be sure that this is somebody that we want to commit to a regular transfusion. Once we begin, we would like to maintain a pre-transfusion hemoglobin between 9.5 to 10.5. The purpose is twofold: to ensure optimal growth and development, and also to completely suppress the extramedullary hematopoiesis so that the patient looks like normal and feels like normal. For any patient, regardless of what condition they have, when we commit them to regular transfusion, it is recommended that we do extended red cell phenotyping prior to transfusion. Wherever feasible, we match them for antigens or minor red cell antigens that are responsible for most of the alloimmunization that we see in many of these patients later on. The red cells that we transfuse in these patients should be less than 2 weeks old, so they have a good lifespan in vivo. The transfusion related reactions are all entirely due to the leukocytes in the red cells. So for these patients, we should give leukodepleted blood. The ideal way to do this is pre-store it just at the time of collection. But if that is not feasible, bedside leukocyte filters, all of you are familiar with. But if you have not seen, please see, it is shown in the OSCE in the exam. So you must be able to identify what it does, what are the advantages of white cell depletion. There is, if your blood product is leukodepleted, there is no need whatsoever to pre-medicate the patient with antihistaminic steroids. And unless the patient has come with severe anemia, is in imminent CHF, there is no, for regular transfusion, there is no need for furosemide. All blood product by law is tested for hepatitis B, C, HIV, and malaria antigen, or at least malarial parasite, but it depends on what technique we use. So the widely prevalent technique is in India is ELISA, but if we use nucleic acid testing, we can very, very significantly reduce the transfusion transmitted infections. And we are trying very hard to get the government to use this widely for every single patient who receives any blood. Next slide. So if we are going to maintain a patient on an optimal transfusion regime, iron overload is inevitable. Each unit gives us 200 milligram of iron, and there is no physiological mechanism in the body to remove this excess iron. This iron overload will go on to virtually every organ of our body, leading to cardiomyopathy, cirrhosis, growth failure, endocrinopathies, leading to even further to hepatocellular carcinoma in later in life. And in the absence of optimal chelation, death in second decade, unfortunately, still continues to happen. So chelation and optimal chelation at that is imperative to maintain a patient in good health. When do we start chelation? We start when the ferritin is more than 1000. So we start measuring it once the patient has crossed 10 transfusions, and at about 10 to 20 transfusions, patient will reach this target, and we initiate chelation at that point. What we need to remember is only a small amount of labile chelatable iron is available in the body at any time. And that's why it's important that the chelation cover is round the clock. So either it has to be given in a prolonged manner, which is how Desferal is given, or it has to be something with a long half-life, so that your body, whatever little chelatable iron becomes available, the drug is on a continuing basis chelating that iron. Next slide. Could I have the next slide? So, I'll come to the chelators in a moment, but there has been a lot of effort made to see that is there a way that we can reduce transfusion requirement? And one of the drugs that was just launched earlier this year is luspatercept. It was an accidental discovery. This was a drug being designed for improving bone health or osteoporosis, and it was noted accidentally that it increases the patient's hemoglobin in clinical trials, and that is why it was evaluated in thalassemia. Phase 1, phase 2 studies showed good response, which led to a phase 3 randomized study, the BELIEVE study, which showed that a significant proportion of patients can respond to this drug and have a lowering of their transfusion requirement. It is given subcutaneously every 3 weeks. Next slide. And about a quarter of the patient, we can expect a 30 to 40% reduction. And some of them can, even have 10% can have a very dramatic reduction and go down from 2 weekly to 8 weekly intervals of transfusion. For us, currently, the drug is prohibitively expensive, but any new development, I think we should welcome that, because cost is just a matter of time. Generics will come, and the cost really comes down, as we have learned from the new chelators. We've learned from the innovator new cancer drugs that the cost comes down, and I am quite confident that in a couple of years there will be a dramatic reduction in cost. Next slide. How it works is by improving the red cell span, improving a late erythroid maturation, and reducing the apoptosis or red cell death, leading to an improvement in hemoglobin. But it's not a magic bullet. It will not get rid of your transfusion requirement completely. So when we come to chelation, we could offer it as prevention, as rescue when there is already iron load, and emergency when the patient is in a dire situation. Obviously, it doesn't take no prizes to guessing that preventive therapy is what we want to do. We want to start very early so that we stay on top of the iron overload in the body, because sustained iron overload is what leads to all the complications mentioned before. Next slide. So what chelators do we have available to us? On the left, you have a Desferal infusion pump, and I'm showing the picture because it's sometimes many residents are not able to recognize in the exam as to what exactly this pump is. It is an infusion, subcutaneous infusion pump, and this is how it is, attached. It can be kind of tape, there is a belt and it can be taped to the body, and it has a butterfly which is 27 gauge, which subcutaneously slowly infuses desferoxamine into the patient. It is a very short half-life, so it needs to be given as a prolonged infusion. We've had this chelator for 40 years, but the cost and the way to administer it made it really difficult even in high income countries for to get compliance. At the bottom, the pump you see, these are pumps available to us now that we can put a 7-day desferal dose in them, and the patient can easily move around, and we often do it when we have to rescue somebody and give them a 24-hour infusion. Defriperone or Kelfer is kind of the drug that came from India because most of our patients could not afford desferoxamine. And Kelfer, we still continue to use it. It has an intermediate half-life, so we need to give it 3 to 4 times a day. The excretion of iron is mostly through the urine. But it is the Defra-Sirox that you see on the bottom that has really transformed the life of thalassemic children. And you have to just take it single day. It is a dispersible tablet. It's much safer. The side effects are much lower, but it is a dispersible tablet. You have to disperse it, and it takes, the whole administration takes about 5 to 7 minutes. On the right is also Defra-Sirox, but it is now available in a film-coated tablet, which you can take with just a sip of water like you do any other tablet. There are no dietary restrictions. And now the one on the right with the blue tablets is really what is widely used in high income countries. In India also, we have now many generic preparations, and I think that will become the predominant chelator that we use in the next few years. Next slide. So this is just a summary because there is not enough time to go through all the different things. So it just shows that the half-life of Desferal is very short, of the Defra-Sirox that we give once a day is long, and it is most effective. Kelfer is most effective in getting iron out from the heart. Defra-Sirox is most effective in getting the iron out from the liver. Next slide. The side effects, and you still need to be aware of them. For desferoxamine, it is ocular and auditory deficits, bone growth, especially truncal shortening, local reaction, hypersensitivity reaction. With Defra-Sirox, it is the GI side effects, mild transaminitis, reversible increase in serum creatinine, sometimes skin rash, but these are not difficult side effects. With Kelfer, it is arthralgias which can lead to discontinuation, and it is the agranulocytosis which is the most worrying thing, which means that the patient needs to have CBC monitoring on a regular basis. Next slide. So if we need to combine. So the first word is missing. It's, we combine Defra-Sirox with Kelfer. We can combine desferoxamine with Kelfer. So if we are struggling, you can use two drugs, requires a little more monitoring. And if we are in a dire situation or patient in CHF, we sometimes rarely do use all the three drugs. Next slide. So what we need to remember is that how hard it is to take medicines day in, day out on an ongoing basis when you are not really able to see the differences immediately. And for us, it doesn't matter which brand you take, which chelator you take, it is compliance that determines the future of your patient. And there are so many reasons, and the reason that we need. So I think our biggest job when we are treating these children and young adults is to motivate them to take this and never scold them, because just don't forget that most of us have never completed a 5 to 7 day course of antibiotics. So when we ask them to take medicines for 50 years, 40 years, I think we need to keep it in mind, come up with tools to motivate them. And I think I personally identify that as my biggest role in the management of a thalassemic. Next slide. So how do we monitor adequacy of chelation? Ferritin is easily available. It is cheap. Every hospital has it. And the trends are extremely important. But the limitations are it is a marker of inflammation and can be misleading. So, we interpret it with caution, but that continues to be the tool that we use on a regular basis to titrate our chelation. Next slide. The standard of care, or the gold standard now for measuring iron overload, is the T2 star MRI, which is just done on a normal 1.5 Tesla MRI. And it uses the properties of iron deposition in tissues with the specialized software. It is a very brief MRI, but you need a child at least 7 to 8 years of age that who can undergo an MRI without sedation. For the cardiac iron overload, it uses the interventricular septum as the area for how much iron deposition is there. Next slide. And this is extremely prognostic information. So if and it helps us to motivate our patients to intensify their chelation, because depending on this value you can predict if your patient is likely to go. So patients who have the value of less than 6 milliseconds are have more than 50% chance of going into congestive cardiac failure in the next 12 months. So if you do this, we intensify chelation, we can actually avert our patient from deterioration. Next slide. And similarly, this slide shows, on the top is a normal liver, on the bottom is a heavily iron overloaded liver, and it just shows that how it measures. There are clear values, and you will get an interpreted T2 star MRI. Just important for the radiologist to be fully aware of the artifacts and the pitfalls of measuring iron overload. Next slide. So we come to BMT, and most of it I will cover here. So these parts that are common to sickle and thalassemias, they will be, I will not discuss much in detail later. The first successful transplant was done in 1981 for a 14-month-old girl from a fully matched sibling, and it has now become, the curative treatment which is possible for most, and there is a lot of support from the government financially. So the financial part is already being taken care of. What is important is to have a donor who's fully matched, either in the family or matched unrelated donor, and the condition of the patient. So we have the Pissarro scoring, which is based on the presence of hepatomegaly, which tells you about the extramedullary hematopoiesis, about fibrosis, which tells you what kind of organ dysfunction there is, and on the adequacy of chelation. So we classify a patient as class 1, 2, and 3, and based on that are the results of your successful transplant. The best age to do bone marrow transplant for these children is between 2 to 10 years of age, before any organ dysfunction or iron overload related complications have set in. Next slide, please. So this slide summarizes the current outcomes reported for various types of transplant very recently. This is from the new EBA, the European BMT group, which summarizes data from all over the world. So it can be as good as 90% if you have a matched sibling donor who is a class 1 patient and has been very well managed and is less than 10 years of age. Next slide. We have the one more, it has been discovered that if you have a high fetal hemoglobin, you have less clinical severity of symptoms. And using this, so if you have hereditary persistence of fetal hemoglobin, your severity is less. And this has been used as a tool to modulate the hemoglobin in these patients and see if we can reduce the transfusion requirement. Next slide. So this has, so number of drugs have been tried. The one that we have used for the longest time in hydroxyurea, so it is for non-transfusion dependent thalassemics. That is almost given to almost everybody. For thalassemia transfusion dependent patients, a few patients may benefit from it, and sometimes in specific situations we do try it. Next slide. Another drug that has been discussed a lot, recently is thalidomide. You're all aware it was a very old drug. It was banned because of the teratogenicity, and but now has had a resurgent and is used in many hematological disorders. Again, it was used in a desperate setting in a few patients with very severe alloimmunization, showed surprising outcomes. Next slide. And a number of hematologists have been using. But we need to remember that it does carry its some certain side effects, such as risk of thrombotic. So you can see on the right a patient of mine who, without monitoring, had started taking this on his own and presented with the infarct, which subsequently resolved. But all it means is that though it can have results, we need to use it with caution. And to do that precisely, because it is a cheap drug, many patients are taking it indiscriminately. And to really identify, you on the left, I'm just sharing with you a study done by Dr. Chandra. This was a pilot study to look at whether this drug works, and it was done in a controlled clinical trial setting, showed a good outcome. And that's why we are currently involved in a multi-centric study to look at this in a little bit more detail. But I would completely advise you not to prescribe it on a routine basis. At the moment, it should be given only under a clinical trial setting with fairly vigorous monitoring. Next slide. So finally, about gene therapy, like I said, it's moved from the lab on the animal trials to the clinic finally. It's extremely expensive. It would cost about 10 crores for an Indian patient to travel abroad to get it. But some work led by Dr. Alok Srivastav at CMC Vellore is happening in this field, and we'll keep you posted on that if there is some success in that. But yes, it is a possibility that we may, it may be available to our patients in the future. Next slide. So just a couple of slides about non-transfusion dependent thalassemics, because their management needs to be individualized. Like I said, almost every patient is on hydroxyurea. It can help to improve the hemoglobin and suppress the extramedullary hematopoiesis. Some of them we will choose to put on a regular transfusion program because they are having a moderate to severe anemia. Their growth is suboptimal. They are having features of extramedullary hematopoiesis or non-healing, or in general are having poor quality of life. They too need monitoring for iron overload and chelation to be started, because ferritin truly does not represent accurately their iron overload. So even earlier than in thalassemia major, and we have guidelines for when to start and when to stop. Next slide. I just want to share with you a couple of complications that are more or less unique to NTDT. One is extramedullary hematopoiesis leading to formation of tumors, like you see on the left picture, which is causing cord compression. In the middle, I'm just trying to highlight that they have a much higher chance of thrombotic complications, and finally, much higher chance of tissue hypoxia leading to non-healing leg ulcers. So, unfortunately, data has shown that adults with NT-DT have actually a worse quality of life than patients who have been optimally managed with transfusion and chelation who have transfusion-dependent thalassemia. Next slide. So we now come to the sickle cell disorders, and any question. I mean, I know there's no way to do justice to all of it, but we can take it in the question and answer session for thalassemia. Sickle cell disorders, we all know why they happen. It's a qualitative disorder because of substitution of glutamic acid with valine in the 6th position of beta chain. This alters the solubility and characteristics of the hemoglobin, imparting a sickling shape when the oxygen tension in the body is reduced. When it returns to normal, the shape is reversed. But with repeated cycles of sickling and unsickling, there can be permanent damage to the red cell membrane, leading to the membrane becoming fixed in the sickled configuration. Next slide. So this again just shows that the because of the presence of sickle hemoglobin, there is polymerization, and when the oxygen tension reduced, it changes a RBC to a sickle RBC, which has two problems. One, it causes vaso-occlusion because it's not cannot navigate, thin capillaries equally well or is not so flexible. And second, because of increased hemolysis, so the consequences of anemia. Next, this is on the right is just a peripheral smear. You will get it in OSCE, which shows sickling of red cells, very easy to identify. Next slide. So the screening test for that is again a solubility test similar to the Nestrov test, but the principle is different. But exactly it is done in a slide, and we use a reducing agent called ox, hydrosulfide, which leads to sickling and polymerization. And again, with the how transparent or turbid the test tube is, it's a fairly good test. But again, there can be pitfalls in its interpretation, so it's a sickle test. So we label a patient as sickle cell anemia when they have homozygous sickle state. These patients have a sickle hemoglobin of more than 70%. A sickle trait or heterozygous state will have a sickle hemoglobin of usually about 25 to 30%. And patients who have co-inheritance with sickle beta or HBD disease, they are referred to as sickle cell disease. Next slide. The confirmation really comes from the HPLC that we have already gone through. And the clinical symptomatology is either because of chronic hemolysis, anemia, poor growth, or because of the vaso-occlusive crisis, which can really affect any part of the body from the cerebral cortex to priapism to leg ulcers to renal infarcts. And there are many types of crises that we see in these patients: the acute sickling or vaso-occlusive crisis, hemolytic crisis with sudden drop in hemoglobin, aplastic crisis, which can be due to a viral illness or vitamin deficiency, sequestration crisis. So in general, sickle cell crises are much more challenging to manage than patients with thalassemia, and we may sometimes miss the early signs. So I think it's very important that we are aware about all that can go wrong, so that we have a low threshold and early prompt action taken, because that would make all the difference between long-term organ dysfunction. And with each of these sickling crises, there is a subtle organ dysfunction, and in a prolonged after many years, they can really have complete failure of a particular organ system. Next slide. So the pathogenesis of hemolysis in this condition is slightly different. So it can have both extravascular hemolysis, because monocyte and macrophage recognize and phagocytize these sickled red cells or entrap these red cells, but it can also be in the intravascular compartment, so slightly different from that in thalassemia. Next slide. So what are the common acute events that lead to emergency room visits? Chronic hemolysis is an issue, but it does not usually lead them to the emergency. So usually it is the acute pain crisis, the acute chest syndrome, acute abdominal pain. They are susceptible to pneumonias. They can present in septicemia or priapism. So these are the common things that will lead to these patients presenting to your emergency room. And like I said, you may not be aware that this patient has a background of sickle cell disease, or it may be diagnosed for the first time with these clinical presentations. Next slide. Uh, this is, globally, there's a global survey as to how often do they have a vaso-occlusive crisis, and because how many of them live in chronic pain, they may not present so much because they have learned to somehow manage it themselves in some way. But 91% patient have experienced at least one major vaso-occlusive crisis in the preceding 12 months, whether or not they may have reported to a emergency room near them. They may have managed. So really, life is difficult for these patients. Next slide. I just want to highlight a couple of presentations. So dactylitis is the earliest presentation which is seen in infancy and may confuse you with multifocal osteomyelitis or other such conditions. They can present with massive sudden increase in the spleen with an acute drop in hemoglobin, can be very challenging to manage. And finally, the acute chest syndrome, where they come in with acute chest pain, and I am showing these x-rays to just highlight that the x-ray at the time of presentation may be completely normal because the radiological changes lag behind. So we see it a few hours later, and we see it 10 hours later, you see it is dramatically worse. And once we have managed it with an exchange transfusion or whatever modality we choose, it reverts back to normal. Many things can contribute to acute chest crisis. It can be the sickling crisis. It can be complicated by an infarction. There can be a component of infection or pneumonia, all of which these patients are exceptionally predisposed to. Next slide. So what factors impact the incidence of sickling? These are the relative concentration of sickle hemoglobin, presence of hypoxemia, fever, dehydration, infection, and some patients peculiarly get it at high altitude again because of the subtle hypoxemia. So nobody should recommend a trip to Ladakh for these patients. Next slide. So it just shows that how far we have come. On the left, you can see that in high income countries, these patients are really having a very good lifespan. And with each successive year, even in some countries which maybe not be high income, the last graph on the left shows that, with each successive generation, with just better community measures, better recognition, prompt management, they have really been able to improve survival. But in many, many low middle income countries, including many of our tribal areas, the mortality for under 5 children with sickle cell disease is extremely high. And in Africa, it can be one of a major cause of under 5 mortality because of the wide prevalence of sickle cell disease. There are a number of reasons, but I think sickle is one chapter you should read in our book, because for the government and policymakers in India, they are very focused on this area. And usually I find that whatever the policymakers are focused on, that somehow finds its way in your theory exam or your practical. So do read up about a little about sickle cell disease. Next slide. Should we screen? I mean, thalassemia screening for newborn is hard because fetal hemoglobin is high anyway, but sickling test can be done, and newborn screening really changes what we are, how we manage these patients, because by earlier recognition, we can avoid any major disasters and really improve mortality. So an American study that was looking at that had to really terminate the study early because there were so many deaths prevented in newborns who were screened early. And similarly in Africa, next slide, It just showed that mortality can be reduced dramatically if we know them right from birth. So in endemic areas in India, it is happening, and we hope that it will happen even more regularly, so that we can also have the reduction in mortality that these studies and countries have documented. So what does the management of sickle cell disease comprise of? So it is the management of acute vaso-occlusive crises and the chronic anemia. So transfusion can play a part, whether it is a simple transfusion or an exchange transfusion or a partial exchange transfusion, depends on the indication, depends on our access to these facilities, and depends on what is our target. So if your target, if you have hyperviscosity already, then giving transfusion can worsen the whole situation, and an exchange transfusion is the right choice at that time, where you don't have anemia but you have symptoms of hyperviscosity. Exchange would be better, but you have anemia, you just want to bring down the HbS below 30%, then simple transfusion is also used, and actually in our country more practically that is much more feasible. We have certain drugs, I'll come to that in a minute, but supportive treatment should be initiated for every single patient in terms of optimal vaccination, including the pneumococcal vaccine, penicillin prophylaxis, folic acid, and if needed, chelation later. They don't need chelation as much because not all of many of them are transfusion dependent. Um, but and they also have some degree of hemoglobinuria, so there is a physiological mechanism of losing iron. BMT is the curative option for sickle cell disease, and again, there have been some major breakthroughs for gene therapy in this condition. Next slide. So for hydroxyurea, this has the drug that has transformed sickle cell disease. It is freely available, and there is evidence regardless of what the indication or what age is. So whatever else they may or may not be on, every patient should be on hydroxyurea as early as beginning at 9 months of age. Really, when feeding is established, we introduce hydroxyurea. The other thing is that we do not use a fixed dose like in thalassemia. The concept for hydroxyurea in sickle cell disease is to take it to maximum tolerated dose, and they can usually tolerate up to 30 to 35 mg per kg. We may start with 10 mg per kg per dose, but we can gradually increase it as long as it, till it controls symptoms or develops any cytopenia, which are virtually, do not happen with hydroxyurea. Next slide. So this is the landmark papers. These are the two studies that established the role of hydroxyurea in babies, which many clinicians were very reluctant about. And it showed that if you started early, as early as 9 months, you can really dramatically reduce their chances of needing a transfusion, acute crisis, dactylitis across the board, and it is now the standard of care across the world. Next slide. If you are worried about monitoring CBCs and cytopenias, you can start with a lower dose. I'll just share a couple of points about the pain management in sickle cell disease. So these are the current recommendation. We should initiate prompt management within optimal analgesia within an hour of starting of a vaso-occlusive crisis. Many of them, all the patients should have ready access to the usual pain medications with them so that they are not struggling. It should be in their medical kit at home. If they come to the hospital and opioid therapy is indicated, what dose do we use? We have to judge what worked for them in the past and if they are on a baseline opioid or not. A short course of NSAID can be added, and it can help to reduce the overall opioid requirement. Corticosteroids are frequently prescribed to reduce inflammation because usually that is what triggers the vaso-occlusive crisis, but they are better to be avoided. If still opioids do not control a severe pain, in our ICU, we can give a sub-anesthetic or analgesic low-dose ketamine infusion. We can use regional anesthesia, And we can also use non-pharmacological measures which work very well for chronic pain. For chronic pain, it is better to rely on non-pharmacological measures and avoid chronic opioid therapy. If still we struggle, we sometimes put them on regular transfusion, but that should not be an indication. And any child who comes like this and is not on hydroxyurea, please start them on hydroxyurea and optimize the dose of hydroxyurea if there is room. Next slide. So what are the indications for transfusions? Symptomatic anemia, aplastic crisis, splenic or hepatic sequestration, acute chest syndrome. Prior to surgery, major surgery, we should bring the HbS down to less than 30%. In pregnancy, try to keep it less than 30%. In primary or secondary stroke prevention, and I'll come to that in a minute, and very rarely in patients in whom we can't control their vaso-occlusive crisis, but there are other modalities to do this, so it should not be used lightly for this indication. Next slide. Could we move to the next slide? So I just want to highlight the menace of silent cerebral infarcts and stroke in these patients. By age of 30 years, and more than half of them will have had either multiple cerebral infarcts or a frank stroke. And these patients, unless we do something about it, they will go on to have many. So on the right, you see a curve that if we choose to take action on this, we can prevent further strokes. But if we do not take action on this, then we will have multiple episodes in the next 48 months, leading to long-term neurocognitive impairment, early dementia, and lots of other neurological complications. Next slide. So what do we do about this? It is recommended that all children above 2 years of age have annual transcranial Doppler screening. Unfortunately, it's not accessible. It's not very difficult, but it's not very accessible to most of us. So where feasible, do use this. And if the transcranial Doppler velocity is abnormal, we need to initiate them on a regular transfusion program to maintain HbS level less than 30% for at least a year. If it is not feasible, then we have abnormal velocity, but this is not feasible, commence on hydroxyurea for treatment. But if the patient has had a stroke, we have no choice but to put him on a regular transfusion program at least for a year. And if the patient presents with an acute stroke, initiate transfusion or exchange whatever is feasible within 2 hours of acute neurological symptom presentation to limit the neurological damage secondary to this stroke. Next slide. I'm close to the end, so just bear with me for a few more minutes. So what drugs do we have? Until 2017, we had only hydroxyurea, transformational drug, very cheap, very easy to use. In 2017, we had L-glutamine, which comes at sachets, is widely available, not very expensive, but it can reduce the incidence of vaso-occlusive crisis. Finally, in 2019, crizanlizumab was introduced. It's a IV injection which needs to be given once a month. It is a P-selectin inhibitor, which is the point at which this whole vaso-occlusive crisis gets triggered. So by acting on this drug can reduce adhesion, sickling, and really prevent vaso-occlusive crisis. Another agent was introduced the same year, voxelotor, which actually prevents hemoglobin S polymerization, reducing hemolysis. So crizanlizumab reduces, the hematology fellows on this group, they may know, they may get a short question on these drugs, new agents in the management of sickle cell disease. So do read up about them, because this one is available to us and we are using it. Voxelotor is not so widely used because transfusion requirement is not really a major issue in these patients. Next slide. Just one slide on HBE disorders, very widely prevalent in the northeastern part of our country. HBE trait can just manifest as microcytosis, usually asymptomatic. HBE disease patients also have very mild anemia, mild distress, splenomegaly, marked anisocytosis and on PS, but they may again not be majorly symptomatic and may be incidentally discovered for the first time in in adults. You'll be asked a question in the exam that why do HbE disorders tolerate much lower levels of Hb hemoglobin and do not have all the other sequelae that we see in other hemoglobinopathies, and that is because of the oxygen dissociation curve is towards the right. So even at a lower hemoglobin, they release much more hemoglobin to the tissues, preventing changes of tissue hypoxia. Next slide. So HBD trait, again, 2% of the whole of Punjab has HBD trait. This is clinically asymptomatic. You may be asked for antenatal counseling for patients, parents with HBD, and HBD on its own does not have any clinical significance. Homozygous HBD disease can have mild anemia, but still may be asymptomatic. It is when HBD combines with HBS, these patients usually have a very clinically severe phenotype. Next slide. So I just want to end by showing that, the field of hemoglobinopathies is not so drab and unglamorous anymore. There are multiple treatment modalities working on various pathways, gene therapy, gene editing, and improvements in bone marrow transplant that are offering many treatment approaches to these patients. Next slide. And also to patients with sickle cell disease, there are many emerging approaches that may find the light of the day and become part of our clinical practice in the future. Next slide. I just want to end by showing a picture of one of my patients with thalassemia major, who's a software engineer, is married to a handsome young man with two beautiful children and leads a full life. The oldest thalassemia in my unit is 52 years old, and every organ is better shape than I am. So we have a race that he has to outlive me to prove that thalassemia is not the burden that we make it out to be. So this should not be an anecdotal story. This is how each one of our thalassemics and sickle cell patients should be. And they just show how if we manage them optimally, that is what we can achieve. Thank you so much for being here today. And I once again apologize on all our behalf for the technical glitches to begin with. And I think we can open it up for questions now.
Thank you, ma'am, for a wonderful presentation. Please stop sharing your screen. Mr. Sushil, please stop sharing the screen. We have some questions, ma'am. What is C-pick and dirty slide?
The C-pick, if I remember it correctly, was the one that had the basophilic staining, and that was a picture of the smear of a HPH disease or alpha thalassemia. That's a screening test. You can ask your lab to do for you. If you have a patient with moderate thalassemia, some splenomegaly, your HPLC has been reported to be normal, but your overall impression is that I have a hemolytic anemia, then it may be alpha thalassemia because HPLC may miss the very early pick of HPH disease. So that's a simple test that even in the private sector just costs like 100, 200 rupees, and you can just ask your lab to do it.
Ma'am, what is the terminology beta plus and beta minus?
So it is, depending on what gene you have inherited, the patients can either make no beta hemoglobin at all, or they can make some beta hemoglobin. So it is not beta minus, it is beta 0 or beta plus, which is one of, it is depends on what is the gene and how severe it is, which is what leads to the genetic heterogeneity in these patients. So if you make some beta hemoglobin, you are likely to have a less severe disease. If you have beta 0, then it will be more severe disease.
Ma'am, when do we suspect alpha thalassemia?
So like I just said, when we have a patient in whom our clinical workup, initial basic workup shows that we are dealing with a hemolytic anemia, The clinical phenotype is like that. The lab results indicate, but we have no, we have no diagnosis. The HPLC comes back as normal. The osmotic fragility is normal. So HPH disease could be there, and it's not that actually that uncommon. It's just our inability to diagnose it makes it seem more uncommon. You can confirm it by doing the mutational testing, which fortunately is now widely available.
And what is the indication for cardiac MRI?
So all patients with transfusion dependent thalassemia and even non-transfusion dependent thalassemia should have an annual T2 cardiac T2 star MRI. It actually looks at both cardiac and liver in the same sitting, in the same 7-minute MRI. After the at any age where you feel a patient will be able to undergo an MRI without sedation. It's not justified to do for this test, give sedation or GA to a patient. We usually use above 10, but some center use even above 7 or 8 years of age. For if they are if the MRI is good, then we can leave it every 2 years. If it is bad, we do it annually or sometimes even 6 months to see the impact. And that is currently if you're asked in the exam what is the standard of care or gold standard, it has replaced liver biopsy as the best tool to measure iron overload in the body.
Is BMT offered only for the thalassemia major?
So non-transfusion dependent thalassemia, that's a contentious question and a great question, but it is reserved for patients who have significant symptomatology. So usually if they are severe enough for us to consider a transfusion program, then they will become a candidate. But sometimes if they are much older, then one has to weigh the risk for this. So, but if they are, so NTDT is a huge spectrum. So if they are on the right end of the severely symptomatic patients, you can consider them. It is all about benefit, weighing the benefit and risk.
Can hydroxyurea be used for thalassemia trait also?
There is no need, sir. It has no impact. And thalassemia trait is a normal person. So why would you commit them to lifetime of hydroxyurea?
Please explain iron therapy in sickle cell anemia.
So sickle cell disease, because, again, the pattern of sickle cell disease in India versus Africa is slightly different. It is actually thought that in India, many of the patients have more chances of transfusion dependence. So if a patient is needing regular transfusion, or we have started it because of primary or secondary prevention of stroke, they may need chelation. But not all of them need, because the hemolysis is partly intravascular, partly extravascular. So some hemoglobin is gotten rid of the body from the body already. So again, we have to monitor for iron overload if you are on transfusion, if you are on a regular transfusion program, either because of chronic hemolysis or because of stroke prevention or any of the other complications. And in that case, you may need it. But in my experience, many of them actually, do not end up requiring it.
Which parts of Delhi are endemic for sickle cell disease?
So sickle cell disease is not endemic to Delhi, but with all the movement from, so Chhattisgarh, Bilaspur, Odisha, those are this, but Delhi is, Delhi is everybody's city. So in your hospital, in Delhi at least, we cannot think of endemicity.
Only in the people coming from the other states.
Yeah, but we are finding, so I think we can just except for saying that they have a higher concentration and lower concentration. We are seeing thalassemias in the south, we are seeing sickle cell in Delhi, but yes, the prevalence ratio is very different.
What is the dose of L-glutamine?
So L-glutamine is available as a 5-gram sachet. So for a young child less than 5, we give half sachet twice a day. For an older person, 1 sachet twice a day. But it causes certain GI disturbances. So I have found that the compliance is not very good.
And what is the TCD velocity, which is significant?
So I think the person already wrote the answer there. That is the correct answer. So it's 200 millisecond. And, if it is abnormal, then we need to initiate. So at least nothing else, at least put the patient on hydroxyurea or increase the dose of hydroxyurea if we do this.
When can we do a HPLC after transfusion?
So, sir, actually, it can, to get a completely accurate result, it's a very long time because the red cell lifespan is so long. But it may give you some value in a hemoglobinopathy patient like transfusion dependent thalassemia. There is no point because you will need your next transfusion prior to in few weeks time, and at that point it will be completely misleading. Not just the fact it doesn't give you a diagnosis, it can mislead you because the HbF will be lower. So they come back with a label of thalassemia intermedia, which misleads the patient, and he is in a false security that I don't need regular transfusion. So my suggestion would be to not actually do it. If it is a patient who has had an occasional hemoglobinopathy, you can repeat it after 6 weeks, but it may take even longer than that to get a proper HPLC diagnosis.
And any target HB for thalassemia transfusion and
We
hypertransfusion?
want to maintain it at 9 pre-transfusion hemoglobin 9.5 to 10.5 gram per deciliter. That is our target. So one should do a hemoglobin, not to keep on doing it the hemoglobin repeatedly, but they get a hemoglobin estimation at the time of their transfusion, based on which they can plan their next transfusion, because we know what is the average increment we will get, how much blood we are giving, and on an average there is a decline of 1 gram per deciliter over the per week for these patients. So we can calculate or estimate their next transfusion rate.
And what are the results of haploidentical bone marrow transplant in
So the
thalassemia?
for thalassemia, the results of haploidentical transplant in the slide that I showed, they have been given as an average of 70%, but they can, individual results from centers vary from 80 to 90% to 50%. So the the EBMT has tried to get what is currently we can quote as an average number, but an individual center can quote a higher number also. The definitely all I can say is that the results of haploidentical transplants have improved, and it can be offered. But again, we need to remember that it is a benign disease. The expertise and experience of the center matters. So one cannot say that what is the result of one center will be the result of everyone. So I think it's
At what levels of transaminases do we discontinue test drugs?
So we have to remember that in thalassemics, the reasons for transaminitis are not just the defrasirox. The iron overload itself may cause the transaminitis. There may be concurrent, we may not have yet identified hepatitis B or C, which unfortunately hepatitis B is more or less well controlled, but hepatitis C continues to be widely prevalent in our patient. They can also have hepatitis A and E. So do recommend hepatitis A to your patients because they will have a more significant or worse clinical course with hepatitis A. The transaminitis, in my experience, has not really been an issue. It is a very occasional patient. So if it's the guideline says up to 3 times baseline, but if it is, we sometimes wait and see. If it's not much, there may be other factors, so we closely monitor it and see, because really that is our best bet to keep this child optimally chelated. And do not, lower the dose or give it up easily on it. Be sure that it is your, it is your agent that is causing the transaminitis.
Can we check serum ferritin levels 2 to 3 days after post transfusion?
Yes, after first transfusion there is no need. It doesn't make any sense, because that is, for iron deficiency also it will not show. For iron overload we do the first ferritin. after 10 to 12 transfusions. So many times we see that at the time of diagnosis, ferritin has been done. That maybe if you are you think that maybe severe nutritional anemia could be a differential, but not from the purpose of iron overload. That for that action label, iron overload is really after 10 to 20 transfusions.
Can we give iron to sickle cell patients?
A very clever question. Yes, sickle cell disease, though they can have iron overload, it depends what is happening because of the hemoglobin. If they have hemoglobinuria, they can sometimes be iron deficient also. It is rare, but it can happen. May I ask whose question was it? Is it a pediatric person or a
Yes, ma'am,
hematologist?
Dr. Vikas Talware, pediatrician.
Okay, but that's a very clever question, I might say.
And there are certain questions that we can answer in the group because they have asked for the BMT centers. And
Okay.
what is the correct age to screen baby if parents are known thalassemia minor?
So the age to screen the
Yes.
optimal age would be 6 months, because by that time the fetal hemoglobin has reached adult levels. But if a patient becomes clinically symptomatic earlier, so the earliest that we've diagnosed thalassemia clinically, because they have come with the features, is at 3 months of age. So it just depends on their genetic mutation. But ideally, if they want it to be ruled out, we should say 6 months.
Dr. Anand has asked about Jehovah Witness and artificial blood. I think Jehovah Witness, they do not take blood products.
Yeah, that's right. So artificial blood, it was in the paper recently. There has been the first success of artificial blood in a clinical trial setting, but it is so far only in the lab. It may become a reality in the future because there has been a recent major investment grant given to that lab. It was in the newspaper, I think, few months ago. But at the moment, it is not, in the immediate future, we are not going to see it. So for that kind of patient, we could, internationally, a patient who has a transfusion dependent condition and belongs to a family who are Jehovah's Witness, the court will issue a court order so that the child can be treated optimally. But yes, if there is any way with hydroxyurea, we may even consider thalidomide adding for that child. If we can comply with the wishes of the patient without compromising the health of the child, one would do it.
Thank you very much, ma'am. If there are any more questions, we'll answer them in the group. And
Okay.
and once again, we apologize for the some technical glitches
Not
today
at all,
morning.
sir. It could have been at any end. So that's fine.
Thank you
And
very
I'm
much.
very impressed. I just want to, once again acknowledge you and compliment you for,
Thank you,
the
ma'am.
whole idea and the execution of this wonderful platform. It's my privilege to be here today. And for all our young colleagues who on a Sunday morning joined, more than, I think, 240, it's very impressive, Dr. Ajay. Thank you so much for making me a
Thank you,
part of
everyone. Thank you, all the delegates. Mrs. Sushil, please.